All right, well, it is 8 o'clock and we will get started on our grand rounds this week. And introducing Dr. Przybelski is going to be Dr. Barzy from our Division of Geriatrics. So Steve.
Thanks. And I'm excited and honored today to introduce my colleague and friend, Dr. Bob Przybelski, as today's Grand Round speaker. Dr. Przybelski is a professor of medicine and psychiatry, a clinician, and a translational collaborative researcher here at the UW for almost 30 years, and also an Army veteran. He received his undergraduate degree at Notre Dame and completed medical school here at the UW-Madison. Then he followed up with residency and chief residency at Fort Bragg Army Hospital before completing a medical research fellowship at the Walter Reed Army Institute of Research. He started here at the UW in the School of Medicine in 1993 and has served in many different roles at the UW and at the VA. Most pertinent to today's talk, he has been a tireless advocate for persons living with dementia and their care providers as the director of the UW Geriatrics Memory Clinic. He has worked closely as the medical director and also as a co-investigator on a number of Wisconsin Alzheimer's Disease Research Center investigations, including the ALERT study, MIDAS longitudinal study, the SYNAPSE project. And he's really been a true systems thinker as he has accelerated care innovations into our clinics on a regular basis and really done so in a very efficient way. He will be speaking today about something that all of us in the field of aging and geriatrics are just really excited about and have been waiting a long time to think about, which is disease-modifying agents that prospectively will help our patients living with memory illness, and in particular with Alzheimer's disease. So without further ado, Bob, welcome and thank you.
Thanks, Steve. I appreciate the opportunity to talk, and thank you, Catherine Vaughn, for helping me set up. This slide just shows that we do have CME approval or credit for this talk. I do have some potential conflicts of interest. I did provide some consultative support to Biogen for their filing. Genentech, I met on one occasion. Reimbursement was donated to UW and Dream Foundation. I don't use any industry slides in my presentation, and any patient data has approval. Objectives of the talk is to look at potential benefits of the monoclonal antibodies, also explain risks or bad associated with the MAB treatment, and evaluate the difficulties in the practical and ethical decisions to treat Alzheimer's patients with the MABs. I'm going to spend a fair amount of time on the background because I really want to provide a good understanding of where these products came from, both the products themselves and the diagnostic tools that are needed to use these products. Then I'll go through the good, the bad, the difficult of the products, and end with the future, which you'll find is very bright. One of the things I like about these grand rounds is I get to find out about other parts of our department, and I'd like to highlight in the start of our UW memory clinics. It's a large multidisciplinary staff of providers at 5 different locations. It includes Department of Medicine with geriatrics, neurology and psychiatry. We have 6 neuropsychologists, 4 nurse practitioners, soon to have 5, 7 social workers, which is an amazing group to support us, 8 RNs, many MAs, 4 administrative folks. And we do something somewhat unique in that we have same-day evaluations. In other words, patients come in with their caregiver, they're evaluated by the neuropsychologist while the caregiver provides collateral information. And then the clinician typically sees the patient with that information, provides a presumptive or working diagnosis, all in the same day. And that's really helpful to the families and the patients. We use standard and advanced state-of-the-art diagnostics that I'll show you as we go along. We integrate our clinical care with research, as Steve was saying, and we're one of the first in the country to be using monoclonal antibodies. I always start talks on Alzheimer's disease with a picture of Alzheimer shown here on the left. Next to him is Kraepelin, his boss, who actually coined the term Alzheimer's disease. Alzheimer's did not do that. Over on the far end is Nissl staining, and you could put on this bench Louis and Pick, were also contemporaries of these folks. So this is really the golden age of psychiatry and the neurodegenerative diseases. Alzheimer has had as a first job, he was a physician in an institute in Frankfurt where he met Frau Augusta, one of the patients who was admitted there, not for memory problems actually, but for behavioral problems. He got to know her, kept good notes, and when he went to Munich, he was promoted, he actually had her brain brought to Munich so he could do the autopsy. And what he saw is shown here in his drawing. It's showing the amyloid plaques, nicely shown outside the cells, and the neurofibrillary tangles within the cells. So Alzheimer had the pathology to look at to make the diagnosis of his 11 patients or so. We don't have that pathology in life. We don't do brain biopsies, obviously. So we have to use clinical criteria to diagnose the disease. And that, as I tell residents, fellows, medical students when they come through our program, making the diagnosis of Alzheimer's is actually very difficult. It's not an easy diagnosis. It's just like if you have a cancer, you got to work them up. You got to do biopsies. You can't just sit down and say a person has Alzheimer's. But we do use clinical criteria, and typically we use the DSM-5 for the clinical diagnosis. As you'll see, there's other criteria. But in general, the clinical criteria is an insidious onset with gradual decline in one or more cognitive abilities, no evidence of mixed or other conditions such as delirium. In 2013, when the DSM-5 came out, they recommended we switch or replace dementia with major or mild neurocognitive disorders. They focus on the declines rather than the deficits in function, focus on memory, less on memory, but more on speech and language. Major neurocognitive disorder would involve two or more abilities affecting independence, and that's very important. It has to affect independence, whereas mild retains the ability to be independent. And in 2013, these criteria came out and said we really should use biomarkers for the diagnosis of Alzheimer's disease. And in the revised text edition of the DSM-5 that came out last year, they said we actually must use biomarkers for the diagnosis. So no longer is it just a clinical diagnosis, or at least we should be using biomarkers. Now in our clinics, in our memory clinics, we actually follow these patients longitudinally, which is also somewhat unique for memory clinics. I have one patient I followed for as long as 16 years to follow her decline. And basically we're looking for normal aging. In other words, we can tell the number of patients that come into our clinics, no, you just have the typical memory loss that patients have. But commonly we see a more progressive loss, and that makes us concerned, especially as it advances, that they would have a major neurocognitive disorder, or what we used to call a dementia. But what we really want to do is we want to find these people in a mild cognitive impairment or mild neurocognitive disorder phase, because that's the place that we would like to intervene. Now, while we're using the clinical criteria for the DSM-5, our academics and laboratory research in industry typically uses the National Institute of Aging, our Alzheimer's Association guidelines for their criteria. And in 1984, the initial criteria that came out emphasized memory loss as a presenting symptom. But in 2011, in the revision, they also added word finding, judgment besides memory, and they defined preclinical Alzheimer's disease, mild cognitive impairment, basically the work on Ron Peterson from Mayo Clinic, and the Alzheimer's disease stages. And they pointed out that there's a vascular contribution to Alzheimer's disease. So this was a major advance. In 2018, the NIAAA criteria were described as a research framework, and it shifted the definition of Alzheimer's from a syndromal clinical or presentation or diagnosis to a biological construct. And that meant that we should be using biomarkers, which they defined as the ATN classification, to define or describe Alzheimer's disease in living people. The A and the ATN is for the amyloid deposition, the T is for tau, pathologic tau, and the N is for neurodegeneration. And in their preface or preamble, you said, these abnormal protein deposits define Alzheimer's disease as a unique neurodegenerative disease. So instead of just the clinical diagnosis, using the biomarkers would firm up, or it's what the classification should be for Alzheimer's. In 2024, there'll be new criteria coming out, and I'll show you a bit of the draft in just a second. But the most important thing in my mind is that it brings together academic, industry, and clinical. It mentions clinical for the first time. So finally, we have one set of criteria to diagnose Alzheimer's disease. The biomarkers that are defined in these draft criteria as core biomarkers are the amyloid, which can be obtained through fluid, or there'd be blood and spinal fluid, or imaging through the amyloid PET. Tau, which could be obtained again through fluid, either spinal fluid, p-tau 181 or 217, or plasma or blood, or through the tau PET. And the N, remember this is the A and the T of the ATN criteria. The N, the neurodegeneration, could be obtained through neurofilament levels, but also through anatomic MRIs, and FDG PET scans. So again, we can clinically obtain these, as I'll show you. So if you wonder, well, how do these biomarkers show up, in what order? What shows up first, even in the preclinical, or what actually the new criteria will consider a prodromal Alzheimer's disease? Early on, you can see deposition of amyloid in the brain and find levels and changing in the spinal fluid. So the amyloid is the first biomarker to change. That's followed by the synaptic dysfunction, which can be seen on FDG PET, which, as I'll show you, we've been using extensively. Tau-mediated neuronal damage occurs later, and then you start to see the actual brain structure, volumetric changes in the MRIs, cognition changes, and clinical function. The point being, again, of this Jack curve, Jack being from Mayo Clinic also, is that we can pick up these amyloid changes and synaptic dysfunction early in the disease on a clinical, I'm not talking here research, I'm talking clinical basis that we do in our memory clinics. So for the longest time, when I started doing the memory work back in early 2000 or 2019, late 1990s, all we really had as a biomarker were the MRIs. And you can see the changes from a normal brain, the hippocampi, this is a coronal view. You can see the hippocampi shrinking through MCI into moderate Alzheimer's disease. But in 2004, Medicare approved the fluorodeoxyglucose positron emission tomography, FDG PET, for differentiating Alzheimer's disease from frontotemporal disease. And as you know, the brain is a very highly metabolic organ. In fact, it's less than 5% of the body mass, but it consumes 20% of the glucose. And FDG PETs with the hypometabolic presentation, which I'll show you, correlates on autopsy studies with neurodegeneration. They correlate with the neurofibrillary tangles on autopsy and with tau PET findings. And more recently, it's been shown that synaptic density, which is the hallmark of Alzheimer's disease when loss of synaptic density, also correlates with the FDG PETs because it's the synapses that consume most of the glucose. Therefore, FDG PETs provide the tau and the T and the N, the tau and the neurodegeneration for the ATN criteria. So one study approved by Medicare can give us two-thirds of the criteria for an in-life diagnosis of Alzheimer's disease. Here's an FDG PET that I obtained probably 6 or 7 years ago on a patient. And this is about as textbook as you get for a FDG PET scan. And what you see on this side is the right cortex, the left cortex, the right medial cut, the left medial cut. And these scans are nice because the GE Cortex software provides an image that looks very much like a weather map. In fact, I tell the patients, okay, you know how you see the weather and you see that this red and yellow and green is coming. That's a storm of some kind or some bad weather. Well, in these projections, in these pictures, the green, yellow, and red are the areas of the brain that are not working. And in fact, in Alzheimer's disease, on the medial cuts, the posterior cingulate and precuneus areas are always involved first. In fact, if those areas are not involved in hypometabolic, this is not Alzheimer's disease. That was shown all the way back in the 1990s. Something you also see is that the motor sensory strips are not involved. But in this scan, you see that the parietal and the temporal lobes, prefrontal cortex, and some of the frontal cortex show hypometabolism. So again, this is a classic view or presentation of Alzheimer's and FDG PETs. Now, more typically is what I see in these early patients that come in with memory problems is a scan that's run as negative by the radiologist. But when I look at them, having looked at hundreds of these things and knowing the patients, I say, yeah, I don't know. I'm seeing some hypometabolism in the posterior cingulate precuneus area. So I tell the patients, well, you know, when you go to a dentist and they say, oh, there's a spot on that tooth, it's not really a cavity, but we're going to follow it. I tell the patients, yeah, there's a little spot here I'm really concerned about. We're going to follow this because this could be early Alzheimer's disease. And in fact, in this patient, 2 years later, you can see it blossomed into a full-blown presentation, hypometabolism in the posterior cingulate precuneus areas, and then more hypometabolism in the parietal, temporal, some frontal. And sometimes I see something else, and that's, I get the scan, and there's a little bit of hypometabolism in the posterior cingulate precuneus, but marked hypometabolism in the temporal lobe, frontal lobe, parietal lobe, and lesser so on the right side. And in this patient with speech and behavioral problems, it's frontal temporal disease. So again, Medicare approved these to differentiate Alzheimer's from frontal temporal disease. And this is an example where it's very helpful to define FTD. But also, sometimes we see a scan that looks like this. And if I went back to show you the last scan, you would have noticed, or I could have pointed out, that in the occipital lobes, there's very little hypometabolism. In Lewy body disease, the occipital lobe is always involved. In fact, that's how the radiologist read this as Lewy body. And perhaps that has something to do with hallucinations. My neurology colleagues have been using the spinal fluid predominantly while we've been using the PET scans. And what they measure in the spinal fluid is amyloid and tau. And basically, what you see in Alzheimer's patients is the amyloid ratios actually drop. You say, well, wait a second. I thought amyloid is important for Alzheimer's. Well, the reason is that the amyloid is dropping in the spinal fluid is because it's being deposited in the cortex, whereas the tau levels, which are shown here, actually increase as brain cells are dying and releasing tau. So that shows us that if you have a patient in this quadrant, it's consistent with Alzheimer's disease versus this quadrant, it's not consistent. Unfortunately, we also get patients in these quadrants. So along comes the amyloid PET scans, which can actually show amyloid in the brain. This is a study that Nate and I and Sterling Johnson had done about 2017. It was part of a large national study. We were part of 400 clinicians. We scanned 17,000 patients. It was a Medicare study, supposedly to support the approval of amyloid scans. We hit the primary endpoint, did really well. Unfortunately, Medicare didn't approve it. But what the scan shows is the red part of this scan shows where amyloid is, and there's always amyloid in the brainstem. There's always amyloid in the white matter, but there's never amyloid in the negative part of the scan or the negative control, which is the cerebellum. So this is a negative amyloid PET scan, which can be very, very helpful in diagnosis. This isn't a positive amyloid scan, obviously positive, the red all over the brain. And this is what we'd see in a person who has Alzheimer's disease, especially if it's later in the development or later in amyloid deposition. Amyloid sprinkled all over the brain, just as if you took like a salt shaker or sugar and put it all over the brain. It doesn't generally localize to one area. But amyloid scans are not approved by Medicare. They're $10,000 to $15,000 each, and therefore out of pocket is almost impossible. So along comes a blood test called Crucivity AD, developed by C2N company. And basically, these were developed and used actually through work done here in Sterling Johnson's lab with our memory clinic patients actually being used. And basically what the lab did is they showed a high correlation between the positivity of this test and the positive amyloid scans. As I say, these tests have become available at the University of Wisconsin, can be obtained through the Fitchburg Laboratory or UW Health. It uses the age of the patient, the ApoE status, which is really nice because when we get the results back, it tells us whether these patients have the ApoE4 gene associated with Alzheimer's and whether it's heterozygous or homozygous. And it also uses the blood measurement of amyloid, beta 42 to 40. It's not reimbursed by Medicare, but in working with this company over the last year or so, we got them to bring the cost down. In fact, since we were the first clinical lab in the country using it, clinical group using it, we really worked with them very closely and again, brought the cost down for our patients. This is what it looks like when you get the result back. You see that a patient, this patient in particular, has a high probability of having amyloid in the brain. Now, shortly after the introduction of our Przybelski AD, which we got in our lab about 3 months ago after about a year's worth of work and getting it in there, along comes Przybelski AD2. Now, the difference between this blood test and the other one is that this actually provides tau. So not only do we get an amyloid level, but we get a tau level. And we get the p-tau 217, which is actually the best of the taus to measure in the spinal fluid or in blood. And it has a little higher positive predictive value than the Przybelski AD. So again, these are clinical blood tests. These are things we can use, we are using. Actually, some of the first in the country or first to be using these. So that leads us into what the main part of the talk is, which is the monoclonal antibodies. And first, I'm going to talk about the good. And as you know, we've had drugs or medications for about 30 years or so that actually improve memory function. In the donepezil, rivastigmine, galantamine. In 2003, memantine was introduced to be used in conjunction with the cholinesterase inhibitors. But in the meantime, even back as far as 2000, industry and academics were working on drugs that would change the course of the disease or become disease-modifying drugs. And my simple-minded thought or approach was always that these antibodies would attach to the amyloid plaques and basically induce the microglia to phagocytize these plaques and basically remove the plaques slowly from the brain and change the course of disease. But actually, these monoclonal antibodies do probably far more than that, in that they not only attach some of them to the amyloid plaque, but they also attach to the other moieties of the amyloid, the monomeric forms, the oliguric, which may be directly neurotoxic, fibrillary forms. And as you see by these double arrows, these different moieties go in and out of the plaques. So theoretically, by attaching to these earlier moieties, we can actually stop plaque formation in the first place. Now, before I get into showing the clinical results from the studies that were done, I should just tell you a little bit about the efficacy endpoint that was used. And that was the CDR, or Clinical Dementia Rating Scale, sum of boxes. Basically, the sum of boxes, the Clinical Dementia Rating Scale, which is defined in 1982, gives you a nice global scale, but it's not very functional for use in the studies. So basically, in 2008, there was an article said, really, the clinical dementia sum of boxes, in other words, adding up the boxes or the criteria, the raw scores was more helpful. So what's measured is the memory, orientation, judgment, problem solving, community affairs, home and hobbies, and personal care. And it's rated from 0 to 3, 3 being the most severely impaired. So basically, if you have a score of 18, your patient is most severely impaired. A score of 0 would be they're minimally impaired. And by adding those up and using the sum of boxes, they could define patients as, for example, being, if they have a 3 to 4, being mild, very mild dementia. And I should tell you that most of the patients, or the average score in these clinical studies I'm going to show you, was about 3. So these are patients who were in very early forms of their dementia. And the score, remember, this is 3 on a scale of 18. So this is a very narrow area. So let's talk about aducanumab, which was first approved by FDA in 2021 via the accelerated pathway. It was the first new medication approved since 2003. When memantine was approved. It's indicated for the treatment of Alzheimer's disease and mild cognitive impairment or mild dementia, approved based on reduction of beta plaques. And that, again, approved on reduction of beta plaques. Continued approval requires a confirmatory trial, which actually was just completed, and likely they'll be submitting for the regulatory approval in the near future. The pharmacology is that it's a humanized immunoglobulin IgG1 antibody directed towards aggregated and insoluble forms of amyloid, reduces amyloid plaques. Plaque reduction is time and dose dependent. And what was interesting is that p-tau was also lowered in the sub-studies of this clinical study. So it's not surprising. It should have reduced amyloid, but the fact that it also reduced tau was a very positive, surprising finding. And this is also seen on PET scans in tau reduction in several areas of the brain. But the CDR sum of boxes varied between the two studies. Now, just reports of the clinical study that was presented in the literature, if you look at the change in amyloid, there were two clinical studies, two phase 3, the EMERGE and ENGAGE. And in both studies, the amyloid was reduced in the patients compared to the controls, where amyloid actually increased slightly over 18 months. The reason there are two lines is because there were two doses studied, the 5 milligrams in blue, the 10 milligrams in purple. There also the change in tau. In the EMERGE study, again, the gray is the increase in tau over the 18 months in the controls, and the decrease in tau as measured in the two doses of the product. But the primary endpoint was actually the sum of boxes. And you see only one of the two studies actually hit the statistically significant endpoint. The ENGAGE did not. That led to the controversy and the approval of aducanumab. So they had the phase 3 studies started out that these studies were actually stopped partway through because of a futility analysis. In fact, the company was saying, well, if these drugs don't look like they're going anywhere, we're going to save millions of dollars by stopping study. So they stopped the trials for about 6 months. And during that period, the data continued to roll in, particularly on the high dose group. And what they did then is they restarted the studies and found out that there was actually a change that could have been significant. By the time that this product reached the FDA and the advisory committee voted 10-1 against approval of this product. But nonetheless, the FDA approved it. How could that be? Well, the FDA, in about a 300-page document, indicated why they approved it. In fact, they approved it as a disease-modifying treatment because it did lower the amyloid, because amyloid was necessary for Alzheimer's, that they considered that a significant finding. And particularly since it was shown in 2 out of 3 of the studies, another study being in phase 2, that basically they did hit the sum of boxes endpoints in 2 of those 3 studies. And in a publication by Cummings in 2021, he also pointed out that if you put together all of the high dose, the 10 milligrams, they did reach the sum of boxes reduction. And in fact, if you look at the NPI, the neuropsychiatric index, there's an 87% reduction from baseline in psychiatric symptoms and 84% reduction in caregiver stress. So that was a justification for the approval of aducanumab. Well, Medicare didn't buy it and Medicare didn't approve it. Nonetheless, the FDA approved it, as I mentioned, in January, or the FDA approved in June. We started using the product in November through a patient assistance, since Medicare didn't pay for it. We entered patients here, and we entered patients from a neurologist who co-managed the patients in Marshfield. 14 patients have been treated thus far with aducanumab. 3 have completed all 18 months. That accounts for approximately 150 infusions to date. No infusion reactions, although there's some other problems I'll show you. 1 patient is continuing to 24 infusions. So along comes lecanemab. After all that controversy with aducanumab, lecanemab had less, certainly, of any problems. It was approved by the FDA this year, the regular pathway, not the accelerated pathway, approved shortly thereafter by Medicare for reimbursement. And it was indicated, as was aducanumab, for treatment of Alzheimer's in the mild cognitive impairment or early dementia phase, approved also on the basis of amyloid reduction in the plaques. They also have to have a continued study, which is ongoing. Mechanism of action is virtually the same as aducanumab, except it's directed more towards the aggravated soluble and insoluble forms, which could be significant in that it's the oligomeric form that's more directly neurotoxic, and lecanemab is targeted more to that. Pharmacodynamics are basically the same, including reduction of tau in the sub-study, and they showed a significant decline in the CDR sum of boxes. The results were shown in the publication, as I indicated. If you look up at the top, they hit their phase 1, they hit their primary endpoint. But as you see, if you look at the placebo group declined in function as you get to the higher score. Remember, up to 18, or to get the higher score, that they've actually declined. But lecanemab also declined, just as Alzheimer's patients decline. So what we saw in these studies, both aducanumab and lecanemab, is a reduction or a decline in function over the period of time, over the 18 months in both groups. But in lecanemab, there was a significant difference between the controls. So they declined not as fast. Amyloid burden is shown as declining here, just as it did in aducanumab. So we, having followed this and working close with the companies, started using the product again before it was approved by Medicare. First patient was an 82-year-old that I had been following for about 7 years. He had shown a gradual decline over that period of time. Any mental state was 26 out of 30. CDR, which is the global scale, was 0.5, very functional. Blood pressure, cholesterol, vitamins, all in good shape. Doing walking, brain exercise, all the things we require of our patients if they're going to get these products. On memantine, no anticoagulants, no supplements, except for B6. MRI did not show any significant problems on screening. But his PET scan that we talked about before, you can see this is about 2017. He does show the posterior cingulate precuneus area involving. He does show some hypometabolic changes in the temporal lobe. And if you look at his amyloid scan, remember how that bright red scan we saw before? Well, now we see just a little bit of amyloid deposition on this early study, which, interesting enough, correlates with the hypometabolism in the brain. So this is a patient receiving his treatment at the CareDirect facility in Middleton. And along comes soon donanemab. Donanemab is a humanized Ig monoclonal antibody, which is probably going to be approved by the FDA later this year. I'll show you the results of the Trailblazer 2, which is submitted to the FDA. Interesting, it was a little bit controversial in that it started out as a phase 2 study, changed to a phase 3, enrollment at a number of sites through 8 countries. And again, they filed for regulatory approval in July and expected to be approved by the end of this year. I have many patients coming in and asking for donanemab. I'm showing a tau scan that is actually in one of my patients. This is not a clinical scan. This is a scan obtained through the ALERT study in Sterling Johnson's lab. But I'm showing it because in this study, in the donanemab study, they did something different. They actually stratified participants by the level of tau in the brain. And then they looked at the group that was considered low and medium tau compared to the high tau group. They did something a little different also in that they included patients as low as a mini mental state score of 20 out of 30 versus aducanumab had to be 23 or above, and lecanemab had to be 22 or above. So they were looking at a little sicker, more prolonged, or patients with more profound Alzheimer's disease. They hit positive study results, as you may have heard. They hit their primary endpoint, which is actually a little different different rating scale. All of their secondary endpoints were met by the 18th month, and 71% of patients had complete clearance of their amyloid by the 12th month. So really very impressive results, which recently have been shown in the JAMA article. And these are graphs from the article. And again, shown that we see the same amyloid reduction that we saw in lecanemab and aducanumab, and the plasma tau level reduced compared to control. I'd like to point out that this is the same plasma or blood test that we're using clinically now, was used in the clinical studies of donanemab. And if you look at the sum of boxes, just like lecanemab, the donanemab study showed patients did decline just like the controls. However, there's a significant difference. There's just 2 graphs. This is the low and medium group amount of tau. This is the higher amount of tau. So let me sum up the good. The good is we got 2 agents already approved by the FDA, one approved by CMS, and another one around the corner that removes amyloid from the brain, considered by the FDA as disease-modifying drugs for the first time ever in the treatment of Alzheimer's disease. So what's the bad? I want you to close your eyes. I want you to think about an immune reaction going on in the body. You can think about it in the synovium, you can think about it anywhere that you might be familiar with, or think about it in the brain. What do you see in this immune reaction with antibody antigen cascade? What I see is the antigen antibody reaction, I see cytokine release, I see vasoactive peptides, I see leakage at the endothelial, microscopic level, and basically you got a brush fire going on of immune reaction that we're inducing with our products. And if that brush fire gets significant enough, you can see what are called ARIA, which in this case is some edema in the frontal cortex of one of our patients that we treated. These are called ARIA, or amyloid-related imaging abnormalities, such that when they get large enough, we can actually pick them up on MRIs. There are two forms. There's ARIA-E for edema, ARIA-H for microhemorrhage. And all of these patients are patients with ApoE4, the homozygous for the Alzheimer's gene, have a much worse indication or finding of the amyloid incidence severity, and typically the deaths that have been associated with these products are in the E4 patients. In aducanumab, there was a 35% incidence across all ApoE types of the ARIA-E, 21% of ARIA-H, lecanemab 13% and 17% in E and H respectively, certainly lower than in the aducanumab. And what we found in the donanemab study is that 24 and 31% higher than lecanemab, but perhaps lower to some degree than aducanumab. What symptoms associated with ARIA can be the following: headache, confusion, dizziness, nausea, vomiting, fatigue, blurred vision, visual disturbance, gait disturbance, seizures. But most of these ARIA are asymptomatic. In fact, in the 6 cases of ARIA we saw, only 2 of them were symptomatic, and they were mild nausea and headache. Other adverse effects, very significant, can be deaths. None have been reported as related to aducanumab thus far. 2 + 1 possible for lecanemab, and 2 patients that were E4, 3 related to ARIA and donanemab during the study. Also, strokes have been observed in aducanumab, and seizures are reported in aducanumab and lecanemab. So definitely severe potential adverse events, although less than 1% in these cases. And there's other problems, such as infusion reactions that can be seen with lecanemab, 26%, typically in the first 2 infusions, 9% with donanemab, and rare with aducanumab. So now we have the good, we have the patient, we have the disease-modifying drugs, we have the bad with ARIA in a fairly high percentage of patients, including very rarely deaths, strokes, seizures. So what's the difficult? The difficult is, first of all, is finding the appropriate patients. Unfortunately, there's appropriate use recommendations that have been published that we use. I'm not going to go through all these criteria, other than to say one of the most important things is to get the baseline MRI, because we're looking for patients with a significant leukoencephalopathy that would be highly likely to have ARIA, and in some cases, cerebral amyloid angiopathy, as is the case of one of our patients, which certainly are going to have possibly even strokes from these treatments. So that baseline MRI is very important. And then once we find the patient, we have to prepare the patient, which means multiple visits, especially to go through the consenting process and making sure that they understand that there's stroke, death, and risk of the side effects. And I always use the say-back method. Typically, when I go from one visit to another, at the second visit, I make them tell me what I told them in the first visit about these side effects. And then it's a matter of getting the best co-management of their multiple conditions, sleep apnea, seizures, vitamin deficiencies we screen for, making sure that their medical conditions are well controlled, treating their polypharmacy, which, as you know, is the most common condition in geriatrics, and getting rid of supplement discontinuation to supplements like vitamin E and ginkgo biloba can actually affect clotting. And then optimizing the patients. All of our patients that we treat have to be exercising, have to be doing brain exercise, have to have the right attitude going into treatment. So we found the patient. Now that we have to decide on the product. So I go through these various pros and cons of the different products. And since patients already know about donanemab, we basically go through all the products. The ARIA, the fact that some are once a month, some are twice a month, one is twice a month. And again, some patients don't qualify because in aducanumab, you can't have aspirin or clopidogrel. You can have those in lecanemab, but not the anticoagulants. Whereas in donanemab, it looks like we can have apixaban and others. So we're now to the point of getting the patient ready where we can infuse them. That's been a major critical path for us thus far. UW and Merida infusion centers are not accepting our monoclonal antibody patients at this point. Leadership is meeting, hopefully discussing in November and December to allow us to use those sites, hopefully to accept patients in February of this year. By February, we have a number of patients now waiting to start. In fact, we have a backlog, and which is why we haven't infused many lecanemab patients to this point. So where are we infusing them? Well, we're going all over the place. We are able to use the infusion center in Middleton for non-Medicare patients. We've used Gamma Infusion Center for many of our patients in Milwaukee. Even Mild Bluff Infusion Center in Boston is seeing our patients, Thrivewell and Skokie, and even one in Michigan. We also have the migratory patients, also known as snowbirds. How are we going to take care of them? Are we going to insist that they stay in Madison or in this area for 18 months? Actually, we're working with places in Florida right now that many of our patients are going, making sure we have a safety net for them there. And the problem with having patients in different sites, especially migratory, is we have to do MRIs following them for safety through the course of their treatment. And there's always the paperwork that we're all plagued with every day. Advanced beneficiary notices, peer-to-peer reviews for the pets, 3 forms for the proclivity test. We have to enter them into the CED registry to make sure Medicare covers the lecanemab patients. Prior auth for the monoclonal antibodies, orders for the infusion centers, orders for the MRIs that are followed. What happens if we have an abnormal MRI? That can take a lot of time. Infusion center restarts if we do follow through on patients who have had ARIA, and calls to companies, which we have with patients weekly, monthly, to find out the latest safety data. So we talk to these people every week or two to find out what's going on. We're very, very close to the industry, which has been very helpful to us. All in all, it takes about 5 to 10 hours to start a given patient into this treatment. But that's not the hardest problem or the most difficult. The most difficult is basically an ethical question: to treat or not to treat. That is the ethical question. Not only is it on a patient-per-patient basis, but on a provider-to-provider basis. Many providers would not want to treat with these products because of their understood treatment or risk-to-benefit ratio. Others, like myself, feel that if I'm diagnosing this fatal neurodegenerative disease, and there is a possibility of treating them, I feel my obligation is to treat. But again, that's clearly on my basis. So let's talk about the future. Let's end on a really, really exciting note. First of all, there's better therapies being developed, more effective, less toxic monoclonal antibodies. And probably the most exciting thing coming in the very near future are the subcutaneous forms. Lecanemab will be coming out, I believe, in the next year in a subcutaneous form. I looked at the data already on what they're seeing. Actually, the pharmacokinetics and pharmacodynamics are more favorable than the IV form. More amyloid is actually removed with the subcutaneous form. There is a little more ARIA, but this would obviate our infusion center problem, allow patients to be treated potentially at home. Very, very exciting, coming very soon. Also, oral agents in development that will dissolve amyloid or prevent amyloid plaques, and anti-tau agents for the tauopathies, Alzheimer's disease, frontotemporal disease, progressive supranuclear palsy, and anti-synuclein agents against the synucleopathies like Lewy body and Parkinson's disease. Can you imagine being able to treat Parkinson's disease finally? Possibly combining these anti-amyloid and anti-tau to theoretically induce remission of Alzheimer's, just like we induce remission of cancer. And you say, yeah, that's probably in the pretty distant future. No, there's actually studies starting now on combining lecanemab with an anti-tau product. And down the road, possibly combining other agents to produce what could be considered even a cure. Really, really cool, right? How about vaccines? Is that a possibility? That must be something of the future. No, actually, it's something of the past. 20 years ago, there was a study done with anti-amyloid vaccine. It went through a phase 2, 372 patients. By patient 87, they had seen 6 cases of rampant encephalitis. And so the study was stopped. None of those patients died. But when these patients were taken to autopsy later, it turned out that their plaques had been dissolved. This vaccine was effective. It wasn't safe, but it was effective. So while I was preparing for this talk, I was going through vaccine associated with Alzheimer's. I happened across this study, which I couldn't believe I had not seen or heard referred to before. These investigators looked at a retrospective view of patients receiving vaccines for Tdap, herpes zoster, or pneumococcus, and they compared the development of Alzheimer's disease 8 years after vaccination in patients vaccinated versus unvaccinated. Can you believe these results? Patients who were vaccinated developed Alzheimer's in 7.2% versus unvaccinated 10.2%. In the herpes zoster vaccination, 8.1 versus 11%, pneumococcal 8% versus 11%. These are vaccines for other things than Alzheimer's, or for amyloid, and yet these patients have a lower incidence or development of Alzheimer's. I mean, if you take nothing else away from this talk, please use this to induce your patients to get their immunizations and say, hey, maybe you'd have less Alzheimer's if you got vaccinated for influenza or herpes or whatever vaccination. Okay, but are we doing anything about this? Are we actually creating vaccines given that other one had failed? The answer is yes. And in fact, the FDA has granted fast track designation to anti-amyloid vaccine in development, which actually targets the toxic form of A beta to reduce plaque formation. It's in a phase 1/2 study now. And finally, we're including Downs patients. None of the Downs patients were included in those previous studies. And also prodromal Alzheimer's patients, in other words, even before clinical presentation. It's a multi-center, multinational study being conducted in Europe, soon to include the US in their later studies. Not only are we targeting amyloid, but tau vaccines are being developed. I saw a really great presentation last year at the clinical trial conference that showed that they have a vaccine now which will induce high levels of antibodies against tau. So, in summary, we have monoclonal antibodies approved by the FDA as treatment for Alzheimer's disease as disease-modifying agents. We are using them clinically, have been using them here for 2 years. The FDA considers these disease-modifying, although there are potential side effects which are prevalent in the use of the mAbs. Patients have been treated here, as I mentioned, for 2 years, and we also have the biomarkers which are used clinically. Again, these are not research, these are clinical biomarkers, PET scans, blood tests for Alzheimer's that are being used by our clinics and that you can use. And theoretically, we will be putting the Alzheimer's patients under remission in the not too distant future. I would predict in the next 3 to 5 years, we will be able to effectively treat Alzheimer's disease. Not only that, but the vaccines are being created now to actually induce an active immunity that could theoretically prevent Alzheimer's disease. So that's my talk. If you're interested or you have patients interested in the monoclonals, please turn them on to the websites alzheimers.org or the ELS forum, which is a little more scientific. As you're waiting for your patients to get into the Alzheimer's clinic, you could do us a favor by getting an MRI without contrast. You can ask for an ARIA assessment. Also, get some vitamins, vitamin deficiencies, B1, B6, B12, folate. Get them optimized because that's what we would do. Get them exercising, brain activities, mind diet, etc. So thank you very much. It's been a pleasure to provide this presentation. I'm certainly open to questions.
Great. Well, thank you, Bob. That was a wonderful overview, and it didn't seem like you were nervous at all. So strong work. Can you talk about the potential of amyloid antibodies to affect downstream tau accumulation?
I wish I could. I mean, I wish I could tell you exactly how they're associated, and I haven't seen a good indication how they're a synergistic effect with amyloid and tau. Some people think it's because of the amyloid starts to affect the vascular system, and it's the vascular system that induces the tau formation. In other words, a neurodegeneration that starts that way. So that's probably the easiest explanation. As amyloid starts depositing, affects the vasculature, tau deposition occurs, tau being a pathologic protein accumulating within the cell. And that's probably the best answer I can give you.
Okay. Then can you talk about, this is more general, from your standpoint, should we routinely screen those in certain occupations for cognitive dysfunction or impairment? And if so, are there criteria, age cutoffs? I know in certain professions, airline pilots, you stop, they have mandatory retirement at certain age. It's been brought up for other professions as well. What are your thoughts on routine screening?
Well, it's a good question, and it's very clinically applicable to our patients too, because a lot of the patients are professors and other things. Well, what's difficult, Lynn, is that the tests that we do in the clinic do not test function in terms of professional function, which is a different function of memory. We can test short-term memory, we can test executive function, which probably is most apropos. Routine screening would be very difficult. I think probably more importantly is if there are functional declines, then I think that should prompt a screening of these individuals. But until that time, it's pretty hard to lay that out as a mandatory functional screening or memory screening of these patients.
Great.
Bob, another kind of related question. There is the concept of cognitive reserve, and you know, that's I think where you hint at with those brain health principles, the exercise, the optimizing other medical conditions. Can you speculate, you know, if there's any specific relationship between these biological markers and measures that you're talking about and cognitive reserve? You know, so thinking a little bit about that proactive side of managing patients who might be at risk.
Yeah, Steve, thank you very much. I meant to point that out on those slides. Do you remember, think back to those pictures I showed you of the FDG PETs. There was the bright red area, the yellow area, the green area. I've had this conversation with the neurologists and most recently with some colleagues at Mayo, and we think that that area is actually a prodromal, or excuse me, is actually a penumbral area, just like the penumbral area in stroke, where there still is viable tissue. And in fact, if we can stop the development of the tau and amyloid and or get them exercising, which has been shown actually in studies to actually increase the metabolism of the brain, yes, that is the recovery. So if you picture how small the red and yellow area is, which is the dead area, and how big the green area is, which is the dysfunction area, I think there is a biologic basis for that reserve.
There's another question, Bob, that relates to the prospect of using subcutaneous lecanemab and other therapies. So I guess, Doctor, one of the audience wanted to just have you maybe describe a little bit more some of the specifics about sub-Q antibody.
Yeah, thank you. Yes, this would be dosed twice a week, and it'd be used because the volume of product, actually they're using more product than is typically used, 20 milligrams per kilogram, which requires 2 auto-injectors. So these patients are going to be very motivated to give themselves 2 auto-injectors twice a week. But the payoff is that actually there was a 14, compared to the IV form, there's a 14% increase in amyloid reduction, but there was increase in ARIA, still less typically than lecanemab or donanemab, excuse me, aducanumab or donanemab, but there was an increase in ARIA, probably because of higher dose. And as I said, the pharmacokinetics and dynamics that I saw were favorable in that there was more of a leveling of the dose, and probably that's why there was an increased reduction in amyloid. But again, very exciting, hopefully to be approved. I think that the Medicare, that the FDA will have a relatively easy time because it's another parenteral form of this product. Basically, they need to show the safety data mainly to get the product approved. I would predict it's going to be approved by the end of 2024.
One other question pertains more to communication with patients. the question is, how do you discuss and frame this with patients, especially when, we're thinking now about this preclinical stage and thinking about people who are relatively asymptomatic, and yet, they may then be submitting themselves to these treatments with possible side effects. So, how do you discuss that with your patients?
Sure. Well, first of all, the patients I discuss these medications with are patients coming in asking for them. In other words, when I make a diagnosis of Alzheimer's, when I get the PET scans back and I say, yeah, it really looks like Alzheimer's, I don't start by saying, and the good news is there's products that are going to take care of this. Now, I first of all, it's got to sink in. And then if they come back in a subsequent visit or call and say, we're really interested in these FDA-approved products or what we hear, then I start talking to them about it. And when we do start talking about it, the way I present it is somewhat the way I presented here. FDA has approved 2 products thus far, possibly a third in the near future. The FDA says that they reduce or slow the progression of the disease, the disease-modifying drugs. But you need to know that while the progression of the disease likely slows, there are definite potential side effects of the products. And then I start hammering those side effects. And so basically at the end of the day, I say, okay, we have potential benefits. And my hopes would be that in 5 years from now, I'm still having this conversation with you or a similar conversation. That's my hope. That's what could potentially happen with treatment. On the other hand, there are very high risk, I would argue fairly high risk of side effects with these products, which could even include death and seizures, stroke. So sometimes I get kind of beat up by my patients and families saying, well, you make them sound so bad. So, well, I'm trying to be honest with you. I want to make sure that if you decide to do this, that you really understand there are potential side effects. And like I said, I go usually through 3 different rounds of consenting.
So I have a question, from a patient standpoint, I think patients often lump all the different dementias into Alzheimer's and not understand the nuances between frontotemporal or Lewy body, Parkinson's associated dementia, et cetera. In terms of where the field is in some therapeutics for these other forms of dementia, is there progress in that field? How do you tell patients who may not meet the criteria for Alzheimer's, but still have, mild cognitive impairment or concerns for other forms of dementia?
Right. Yeah, it's a sad time when I actually show them a Lewy body pattern on my FDG PATs or frontotemporal disease, because there's not a lot of positive things I can say at this time. A lot of research is being done in Northwestern and other centers, UCSF, in frontotemporal disease, some Lewy body areas, I think Johns Hopkins in particular. Unfortunately, other than the fact that their industry is working on the monoclonal antibodies, and so forth, there's not a lot of progress right now, Lynn. There's not a lot of things I can say other than stay active, stay healthy, keep yourself in shape so that when these products do come along.
And then when you mention exercise as being a benefit, what is your exercise prescription? How much? Is it running a marathon? Is it, walking around the block? How do you advise your patients?
Yeah, and this is, appreciate you bringing this up. Actually, Ozayama Okonkwo's work and others have shown that exercise does actually improve cognition, does help slow Alzheimer's development. My prescription, which I've been giving for about 20 years now, is basically I want 20 to 30 minutes of an easy exercise every day. And you can imagine for most of my patients, that's a big deal because they're not exercising regularly. And so basically I say, okay, start out at 5 to 10 minutes. And I always tell them, I said, pick a time of day, 9 in the morning, 3 in the afternoon, whatever, pick a time of day and say, okay, everything stops at 10 in the morning, drop everything. I'm going for a walk, or I'm getting on the treadmill, or I'm getting on the exercise bike. People come to visit you, they go with you. It's got to be that rigorous. And so that's basically how we do it. And I got to tell you that when the patients that come back, that patient I've been following for 16 years or whatever, I got to believe the exercise is doing something because they don't seem to be progressing like my regular patients.
Great.
Bob, we are more or less on the hour, but I wanted to say that there were a number of comments and Q&A things just lauding you on the clarity, being such a fantastic talk, being a very important talk. I think there was someone who commented that they want to know more about what's going to be known about these diagnostic and treatment approaches in the future. So they're already asking for you to come back. It's clear that this is an issue that affects all of our lives, either at a professional or a personal level. And I want to thank you for really explaining some of this in ways that I and I think many others can understand, and also understanding that although this has great promise, there are also clear and calculated risks that we'll need to be thinking about. So I don't know if you have any final comments, but thank you again, Bob, for a wonderful talk.
Thank you, Steve, and thank you, everybody, for being here.